All right, if everyone could be seated, we'll get started. It is my pleasure today to introduce Dr. Carrie Ann Terrell. Some of you know her well, others have not had a chance to get to know her, so I think this is a good opportunity. Carrie is the head of General Ob-Gyn, and she is located here on this side of the river in the professional building. She collaborates closely with Kiki Sarafoglu in the Disorders of Sexual Differentiation Clinic. She collaborates with surgery, with dermatology. She is available for young children to come to Explore Clinic, and for adolescents, they can just come to her clinic right here nearby. So we should all be utilizing her services. And she's going to talk about contraceptives and also a little bit about how they can be used for irregular or difficult menstrual periods. So these are topics that touch all of our female patients. Carrie?
Thank you. Great. You might want that for questions. Huh? Yeah. Okay. Yeah, so my group here at the U, we're 8 OBGYNs, 8 certified nurse midwives, a smattering of nurse practitioners, 2 psychologists, massage therapy, if you want to come over for that, it's a really nice option. And we have a position posted for acupuncture. Now I know you guys have peds acupuncture, but to date we haven't really had a good option for adult acupuncture. So our plan is to share that position with the chronic pain clinic over on the East Bank. My clinic is called Women's Health Specialists, UMP, Women's Health Specialists. And then so sometimes there's some confusion. There is a Fairview OB group in our building. They're on the 7th floor. We're on the 3rd and 4th floor. And they're called Fairview Riverside Women's Clinic. So they're a fine group. I'm not saying you shouldn't call them, and if you're already working with them, absolutely fine. But just so you know, there are 2 groups here on campus. All right. So I have no disclosures. I will occasionally use brand names, and that's not because I'm promoting them. It's just because there's only one name. There's only one brand of that thing often. So I'll try not to do that, but if I do that, forgive me. And I think that's it. I do have some things I was going to pass around, and maybe I'll start with Peter, but maybe Peter, if you can send them around slowly. So you just do like one every 10 minutes or something, 5 minutes. So these are teaching tools for the different contraceptives I'll be talking about. So you have a little hands-on show and tell there. Okay, so we're going to talk about basic contraceptive methods, how to practice patient-centered contraceptive care, evidence-based guidelines, and then the middle I shoved in a full and expansive lecture on irregular bleeding in the adolescent female. Not totally true, but I will address some of those issues you guys struggle with irregular menses in your adolescent girls. So what do we know about contraception? In short, contraception's good for women's health overall. So from a public health perspective, this slide is looking at the log of maternal deaths compared to introduction of contraceptive or meeting unmet contraceptive need, and so the rate of death goes down. This is a worldwide data slide. Another way to look at that by country, the blue line is maternal death before an unmet contraceptive need was addressed, and then the red line is after. So for example, the largest improvement we see is in sub-Saharan Africa, where there were 204,000 maternal deaths, and then when we saw some contraceptive need decreased significantly. How about here in the United States? So the good news is that a little more than half of all pregnancies reported, which pretty much all pregnancies are reported. Every time we do a delivery, we have to fill out a Minnesota Department of Health data bank report, and same for all abortions and miscarriages. So generally, we have pretty good reporting of these things. So more than half are intended. Great. The other half, or slightly less than half, are unintended, and about half of those are women or girls actively using some form of birth control. So, we have this pink quarter that we need to address. So there are women or girls who either don't have access to contraception, aren't using it, or don't know how. And then we still have the people who are using contraception, perhaps not optimally, so perhaps ineffectively, or even if they're using it perfectly, the conception rate is still not zero, right? So the only way I can absolutely guarantee you will not get pregnant is if a girl is not having sexual encounters with a male person, or if she does not have a uterus. Those are pretty much the only ways I can guarantee she's not going to get pregnant. So, and I think we've teen pregnancy rates are decreasing, and this slide is from 2011, even lower now. This data is always about 5 years behind. So birth rates are down, pregnancy rates are down, and then thus, therefore, abortion rates are down as well. So when we approach contraception from public health standpoint, our goal is to meet that unmet need. So those unintended pregnancies who are not using birth control and or the unintended pregnancies who might be suboptimal using birth control. We need to facilitate effective use. So it can't be hard, right? Particularly for your adolescent patients. It cannot be hard or it won't happen, it won't work. We should make contraception available at all points of care. That includes you guys. And we need to work individually to find a method that's going to work for each individual person. Okay. Oh, so we had a discussion about this in my clinic the other day about why. So are we doing a better job? Are we providing better contraception for teens? Is that why their pregnancy rate's going down? Maybe. I mean, we're definitely inserting more IUDs, using other contraceptives in the past. The Affordable Care Act made all contraception covered and free for patients unless your employer had a religious-based exclusion. Do we have decreasing fertility in this country? So is it that patients aren't getting pregnant as easily? Because we certainly see that in older women. And or are teenagers having more relationships and actually less touching? One of my colleagues said absolutely not. I have a 14-year-old nephew. There is touching. Okay. So if we look at contraceptive methods, hi Kiki, from least invasive to most invasive, or least effective to most effective, this is the scan that we see where we have condoms on one end and then permanent contraception on the other end with the IUDs down on that end as well.
This is just for my work, sweetie. Learning.
So if you're counseling a patient or her family about contraceptions and you're quoting your success rate or failure rate for the various means, we do talk about perfect use and typical use. And so, for example, your basic birth control pill is quoted as being 99.9% effective, right? We tell women that all the time. In most typical users, that rate is probably only 91% effective. So as many as 9% will fail. And generally when we talk about birth control rates, we're talking about percentage of pregnancies amongst all users in a year. So for people using birth control perfectly for a year, 99.9% of them will not get pregnant and 0.1% of them will. Okay, natural family planning. I am not an expert on this, and I do not counsel patients on this, and I don't think you should either. Plus, it's not really something to recommend for an adolescent. But if you were going to, I would send people to a trained instructor. And there are several in the Twin Cities, and you can just Google natural family planning and find some reputable spots. Because these methods are extremely detail-oriented. And I have to say, they can be quite successful for many women, particularly women who are in a committed relationship. And by that, I don't mean necessarily to each other, but to the process. So if there's a male and female partner, and both are committed to not engaging in vaginal penile intercourse on the days they're not supposed to, then it works. It also depends on the female partner having an absolutely menstrual cycle. So that is not necessarily the majority of women.
Can we put it closer?
Okay. Barrier methods, again, with perfect use, not so Condoms are, you know, pretty good, 2%, not bad, 2% failure rate. Typical use, probably closer to 20%. The nice thing about barrier methods is they're generally available over the counter, so that helps with access. Okay, hormonal methods. So I wanted to talk here a little bit about male contraception because it's something that inevitably comes up. So when we think about trying to provide contraception, so let's just think about it physiologically. So in the man, we have production of billions of sperm every day, right? Constant production of brand new sperm. And another kind of the good news is most of them they're broken, right? So they're not a good shape. They don't swim in a forward fashion. But, you know, maybe 1% of them are good. They have pretty good shape. They swim in a forward fashion. They kind of know how to find the egg. And you only need one. So out of all those billions, even if only 1% are decent, that's enough. So with women, when we think about contraception, so we're born with a set number of eggs. And each month, we work really hard to release just one or two perfect ones, right? So this whole thing has to happen. So there has to be some estrogen. And what does the estrogen do to the endometrial bed? Anybody? Med students? Anybody? Estrogen. Builds it up, thank you. So you're building this nice, luscious bed for the egg, and then you release, so then you have to have an LH surge, right? So the LH surge happens, the egg gets released, and then it starts to travel down the tube. And then what does the corpus luteum produce during that second phase of the cycle? So the egg's out, corpus luteum starts producing that other female hormone, not estrogen. Thank you. So progesterone. So then the progesterone starts building up, and then maybe this is women start seeing a little mood change, a little bloating, a little breast tenderness, all these things associated with progesterone. And then that starts to decrease, and then that egg didn't get fertilized, and so that endometrium sheds. Okay, so back to contraception. So as you can imagine, it might seem easier to inhibit that one egg than those billions of sperm, which I'm a feminist, so I'm not saying that that's not why we haven't focused on male contraception. I'm just saying physiologically that may have had some impact in our science. Okay, so that said, they did just test, I don't know who they is. Someone is testing vasal gel, it's like vasovagal gel, that they're injecting into the vas deferens, and that is it's like a glob that sits in there and supposedly inhibits the sperm from entering the semen. So just like a vasectomy, but like a temporary vasectomy with a glob of stuff injected there. So they're doing that in primates, which so far seems to be effective, with 0 pregnancies, and the couples are watching. Okay, so back to hormonal methods. So these methods are designed at inhibiting ovulation, right? That's their primary goal. So we're going to mess up, by giving hormones, we're going to mess up that whole pattern we just described. And they're pretty darn effective when used properly. And they also probably, because of some of those hormonal changes, even if ovulation's not blocked, which we know it's not in every single cycle and every single user, it creates enough of a hostile environment that generally impregnation does not happen. Okay. And I'll talk a little bit more about pills in a few minutes and help you guys know how to pick one. But right quick, so IUDs, so these are what we call LARCs, long-acting reversible contraceptives. There are some grants for women to receive LARCs for free if it's in a teaching institution. But again, since the ACA, and generally most women in Minnesota are covered by insurance in some way or fashion, we don't use these grants very often here in this state, but they are available. So the copper IUD lasts for 10 years, 99.2% efficacy, again over 1 year, has to be placed or removed by a provider. Side effects with this are quite often, especially in the first few months, periods are heavier and more painful. But over time, that may regulate itself and become more either tolerable or may decrease. And upon removal, immediate return to fertility. So those of us who are older might remember some bad PID or toxic shock syndrome type cases when we were children from one of the IUDs that was introduced at that time, the Dalcon Shield. But these IUDs generally do not have that risk of PID, do not have that risk for TSS, and because we improved the string. Apparently bacteria can climb the string, and so we got really smart about string. Now it's much more like fishing line and less like string, so apparently that's brilliant. But with the copper IUD, there is still a small risk of PID upon insertion if gonorrhea or chlamydia are present at the time. So that doesn't mean we screen everyone beforehand. Our data shows that you can go ahead and do your insertion, test at the time. If they're positive, treat them the next day or two. You should not end up in a situation where you have PID. So it's perfectly fine to do day of insertion the same day you're doing the gonorrhea chlamydia test. Okay. And then there are several Levonorgestrel IUDs. So this is basically your progesterone-containing IUD. And there's the original 5-year one is still on the market, and there are 2 new 3-year ones that are a little bit smaller. So in those things I was passing around, the 5-year one's a little bit bigger blue one, and then the smaller one is the pinkish one. Not a huge difference in size, but if you're looking, if you're thinking about one of your adolescent patients, one of the smaller ones might be easier to insert. Efficacy comparable to the others, has to be placed and removed by a provider. And generally with these, over time, women or girls become amenorrheic. The first few months there may be some continued spotting, it may be irregular, it may be more of a cycle on time, and then generally decreases and abates. Okay. And with this one, the rate of PID upon insertion is not even as high as with the copper one. And again, even with that, it's not very remarkable at all. Okay, then we have the Nexplanon going around in the circle, or in the audience is like a fake arm, and you can feel the implant in there. Now it's a single implant. When I first started practice, it was a 7-rod implant. That was dumb. But here we are, we're good, we're down to 1 rod. And that lasts for 3 years. And the biggest side effect with this is irregular bleeding. And that pretty much lasts the whole time. So unlike your progesterone IUD, where you might have some irregular bleeding for 3 to 6 months, this can be for the entire 3 years. So that can be a major patient dissatisfier, and it's probably the #1 reason we remove these. Okay. Less effective contraceptives. So the every 3-month progestin injection. This is, I think, for a long time, this was touted as a great birth control for adolescents, and it still can be in many of your patients. Again, very good efficacy. And why is it good for adolescents? Because it's not dependent on them doing anything except showing up once every 3 months for an injection, which many of them can now get in their school, health service, or somewhere that's convenient for them. So similarly to the progesterone IUD, you do get a decrease in blood loss over time. So if you have a heavy bleeder, if she can stick with this long enough, she may become amenorrheic, or at least only have very light spotting. Deleterious side effects are decreased bone density. And we definitely see this in all users. And generally, it reverts to normal upon cessation of the birth control. And there is a delayed return to fertility and or normal cycles. So if you have a patient who's used the 3-month injection, either for 1, 2, or 3, or multiple doses, once she stops, it's not going to be out of her system immediately. So she's no longer protected against pregnancy, but her cycles may be irregular for up to a year. And there can be really remarkable weight gain with this method. And so I would caution in adolescents with obesity, this may not be the best contraceptive for them. Studies show as much as 5 kilos. I think in our practices we've seen 30, 40, 50 pounds within 1 or 2 dosing cycles. So it can be really marked. Okay. We don't have this in the United States, but in several other countries, there is a combined hormonal monthly injection. I think we had it here on the market for a while, maybe 7, 8 years ago, not used here. And then there's also a vaginal contraceptive ring going around. Again, very effective, can be used continuously. So this little vaginal ring sits in the vagina for 3 weeks, is removed for a week, during which time the girl has her menses. A new one's placed for 3 weeks, removed for a week, have menses, etc. It's a great birth control. It's nice too because since it's not oral, bypasses the liver, right? And so you get better absorption. So if girls are having breakthrough bleeding on their birth control pill or other side effects from the pill, this can be very helpful to use a transmucosal method. The hard part is some adolescent girls are not comfortable reaching into the vagina to place or retrieve the ring. Placing it is actually pretty easy. So it goes in pretty easy, but then after 3 weeks, it's really worked its way up there, and it's kind of deeply around the cervix. And so there's a little bit of digging sometimes to be able to get that out. Okay. All right, the patch. So similarly, you can do 3 weeks on, 1 week off with a patch. We get to put on a new patch every week. Again, for adolescents, not too bad of a regimen, pretty easy to remember, especially if they have help from parents. Pretty good efficacy. Application site problems. Generally, the patch is designed pretty well, so it should stick on clean, dry skin pretty well. It's not supposed to come off in the pool or with physical activities. Undoubtedly, they do, and so I usually give people a prescription for an extra patch in case one falls off. But with girls and women with BMI over 30, there may be decreased efficacy. Now, the company didn't test the patch. The original FDA trials were only in normal weight women, but there was a smaller study of 3,000 women published in 2002, and I apologize, I did not put this resource on there, published 2002 in Fertility, Sterility, where out of those 3,000 women, only 15 got pregnant. Fine, that's pretty good. But 9 of those had had a weight of over 198 pounds. They didn't report it in BMI, they reported it in weight. But for an average weight person, or for an average height person, we can maybe imagine that's about a BMI of 30. So we've adopted kind of this cutoff for BMI greater than 31 or 32, maybe to consider an alternative option than the patch. Okay. Everyone's favorite birth control in the United States is the combined oral contraceptive, or your basic birth control pill. So this contains estrogen and progesterone. And there's a whole variety of formulations, so we're going to go through some of those. Again, with great use, with perfect use, very effective birth control. And this is where I'm going to talk a little bit about continuous versus cyclic dosing. So generally, so birth control pill was made in the 70s, and the scientists, probably all men, thought that, when we're suppressing ovulation, we're inhibiting growth of the lining, but women are still going to want a period. Fine. So they made the pill like this, right? So, you have 3 weeks of active pills, and here's about where you suppress ovulation, great, and then here, and so you've really not built up any lining, but then wham, bam, we're going to give you a bit withdrawal bleeds. These are placebos. So we've abruptly stopped your progesterone, and we know when we stop progestin in the natural cycle, we bleed. When we stop progestin in the fake cycle, we bleed. And so there you have it. Now what we learned as gynecologists then throughout the 80s and 90s is for women or girls with disorders in which this week can be very painful or excruciating or symptomatic because of endometriosis, dysmenorrhea, headaches, what have you, that you can do continuous dosing. And it is completely safe to do continuous dosing. So you throw this away and you just start a new, you only take yellow pills, right? Or whatever color your pill pack is, because they're all different, trust me. And some of them are round, and some of them are square. Okay, so inevitably then the mom's there, right? And she says, oh, but I heard it's really dangerous if you don't have your period every month. Okay, well that's, technically if you're not on birth control, you should have a period at least every 3 months. because yes, you could be building up lining, hyperplasia, precancer of the uterus, right? So, but when you're on this, we're suppressing that estrogen surge, we're suppressing the buildup of lining, you're not gonna get that. So it's perfectly safe to use pills or the patch or the ring continuously without a withdrawal bleed. And then someone came up with a brilliant marketing idea of having 3 months of active pills, 1 week of placebo, right? And that was a better sell to some families or patients because they thought, oh, good, having a period, right? But really, it's not necessary. And if girls are symptomatic during that week, it's definitely not indicated to have a withdrawal bleed. Questions about that? Okay, I convinced you. All right. Oh, so the other thing we know about birth control pills, which is probably true about other hormonal contraceptives, but we haven't studied it, is women or girls who use birth control pills, combined estrogen progesterone pills, for 5 years or longer during the reproductive years have lower rates of uterine and ovarian cancer. Okay, why is that? We don't know, but probably we're ending this cycle of incessant ovulation. So, if we think back to caveman times, we were always pregnant or breastfeeding. So not a whole lot of ovulation going on there, really suppressed. In typical modern day America, not pregnant or breastfeeding all the time, although that could change. And so we're kind of mimicking that, right? So if we put women on the birth control pill or other form of contraception, we're inhibiting ovulation for them. Because when that incessant ovulation happens, that's when we think mistakes can happen. And mistakes are what? Genetic mistakes, which are what? Precancerous. So that's kind of the theory with that. No increased risk of breast cancer in those studies. Mm-hmm. Brilliant question. She asked, how do you get it dispensed in the way that a person can take only active pills? You have to write an epic, continuous dosing, period, no placebo pills, period, dispense 4 packs for 3 months. So no one's packaging it that way. But if you write that, generally the pharmacy will do it. The insurance company may not pay for it because they may consider that a 1-month supply. So patients, good point, because patients can really get in a bind or a little bit of financial straits sometimes. Continuous, no menses. Yes, until you want to get pregnant. Then you stop your pill. Good point. I'm going to get to that in a little bit. I have a slide on that. No, but some people. Okay. All right, then what if you have a patient with contraindication to estrogen? So there are these progestin-only pills. Commonly we use these in the postpartum period as estrogen may decrease breast milk supply. But there may be other indications for them in your patients who have coagulation disorders or something. So again, we usually say, well, they're not as effective as the real pill. Well, that's true, but it's not bad, right? I mean, if women take it and they take it every day, it's still very, pretty good use or pretty good efficacy. So you can see that pack is all active pills. So there's all progestin all the time. Do women still get a period on these? Quite often they do because it does not completely override the system. And so women will still often get a monthly period, but not necessarily. Okay, how to pick a pill. So there you are, you're in your clinic, you're all alone because you're done with residency, and patient wants a pill, and you go in Epic and you write pill, and there's 8,000 options. So, okay, so when we think about your hormones, think about what each category does, and then think about what it is you're trying to help that person with. Is it acne? Is it endometriosis, bad periods, what have you? Then you think about your progestins. So the majority of pills are all ethinyl estradiol. So the estrogen is pretty much the same. There's one brand or type that's different, but otherwise the estrogens are all the same. It's the progestins that change. It's the progestins we've improved over time. So if you're treating a patient with acne, obviously you don't want to pick one on the far right that has more androgenic properties, right? So you're going to try to pick something that's low estrogenic property list. And I would say once you've sort of found one, kind of find a favorite and stick with that, just because it just makes your life easier. So for us, this latest progestin, the drospirenone, is obviously one of our favorites because it has pretty low side effects in all three categories. And it's still a very effective pill and is FDA approved for acne. And then you're looking at that and you're thinking, drospirenone, isn't that Yasmin? Yes, it is. And didn't they get some sort of black box warning from the FDA? They did, and then it was lifted. Everybody forgets that part. So, and then they had late night TV ads about call your lawyer if you've taken Yasmin. So what was that all about? Well, so there was an increase in DVT when drospirenone came out amongst users, and with deep dive and with real exploration of that data, what we found is that there's an increase in DVT when we switch pills. So because this progestin was touted as being so great, and I do think it's great, a lot of women switched, and there was an increase in DVT. And then if we look at the actual data for drospirenone, it may have a slightly higher DVT rate. So for all oral birth control pills, the rate is 3 to 9 episodes per 10,000 woman years. I don't know how they come up with that data, but whatever, fine. And then drospirenone could be as high as 9 or 10. So we have 3 to 9, and then maybe 9 or 10. So maybe it's a little bit higher scale. So certainly, if you are working with a girl who may have some sort of clotting, theoretically you would be putting her on estrogen, but let's just say, maybe you wouldn't pick this one. Okay. And then some of you are thinking, okay, drospirenone, it's a little bit like spironolactone. Do I have to check potassium? So we've looked at that as well. So in a study of, a small study, 49 women, at least 17 of whom had moderate kidney disease. The rest had mild kidney disease. There was no change in potassium levels. So you don't need to, you can prescribe it safely as long as women have anywhere from none to mild to moderate kidney disease.
Fair.
Okay.
Fair.
Here's my one bias.
Come back here.
Biphasic and triphasic pills. So I don't know why they made these. Well, okay, they made these to mimic the woman's cycle more naturally. And usually when I'm prescribing a birth control pill, that's exactly what I do, right? I want to eliminate her natural cycle because I'm trying to improve whatever condition I'm trying to improve for her and or make her not get pregnant. So generally these are more associated with breakthrough bleeding, mid-cycle headaches, other things, because the progesterone is vacillating throughout the cycle. So my personal bias, don't use these. If you have one you love and it works for you and patients love it, don't change it. That's, right, because changing is dangerous. So that's fine. But I wouldn't make one of these your favorites for the get-go. I would use a monophasic pill. Okay. So then now you kind of have some idea which progestin you want to use. Again, like I said, the estrogens are generally the same except for that top one. So now you have, this is a nice slide, helps you know some names. You can actually now type into Epic to try to get what you want, right? And then the only thing I would caution against, Epic's pretty good with patient insurance coverage because even though the ACA says all contraception should be free, not all ones are free. So, say you type in Ob-Gyn
or your computer.
If you get a red X, just find something similar in that category because most likely the insurance is only covering one of each type of progestin, so you just have to find the right brand. Your pharmacist can help you with that too. So dosing, we didn't talk so much about the estrogen dose. So, you can see we go from 20 to 35 micrograms. Really, the 50 micrograms we're only using in acute situations. But for your 20 to 35 microgram pills for the estrogen, it probably really doesn't matter which one you pick. There's some data to suggest that in more obese girls, the higher doses may be more effective, but then they're also at higher risk for clot because they're obese, and then now they have a little bit more estrogen. So I would say to pick a middle-of-the-road pill, either 20 or 30 microgram, you should be fine for the majority of your patients. Okay. Was that somewhat helpful or just more confusing? Good, okay. Okay, so here's a mini lecture on abnormal bleeding. I'm gonna try to finish up in the next 10 minutes, because then I think we have 15 minutes for questions. So you guys, I mean, you guys should know, your pediatricians, what's normal for menstrual cycle in adolescence. And, you know, it can be a little variable, right? But generally, cycles should be 21 to 45 days, lasting 7 days or less without excessive bleeding. Okay, if it's not like that, what should we be thinking about? So obviously, the most common causes are pregnancy or interruption of the axis. So if it's 1, call me. If it's 2, call Kiki or Brad Miller, Brandon. And then for everything else, I'm going to call you. So, you know, obviously, if she's having menorrhagia, most adolescents with menorrhagia should be worked up for a coagulopathy. If it's more irregular long cycles, maybe it's a PCO or hypothalamic problem, obviously thyroid disease, all these kinds of other things.
Please mute your phone.
So let's just assume you've worked her up and it's not any of those more treatable things, and really she just has irregular and or heavy cycles, and you think, okay, I want to introduce some birth control here because her mom's frustrated and scared, or her dad, or, you know, her guardian, and, you know, how can I address this? So right off the bat, probably the easiest thing you could do is to start a monophasic pill. And I would start in the cyclic fashion, particularly if she's already irregular. So you already have a confused uterus, you already have a confused axis. You don't want to try to go continuous right off the bat. You want to start with a cyclic program and get things sort of under control. And then if you want to graduate to a continuous program once she's regular, fine, you can do that. But I wouldn't do that right at the get-go. And it's going to take some time, right? So I tell these girls, you know, I can't make your uterus behave with your first pack of pills. You need to do it for at least 3 to 6 months. What if ultimately she wants an IUD? Okay, that's a great method too. But again, the IUDs take how long to work? The progesterone-containing IUDs, 3 to 6 months. And so it's not going to get you immediate control of her cycle. And so sometimes what we'll do is start with a birth control pill for those first 3 months and then transition to the IUD. And we talked about when to try to use continuous dosing later. Okay, so what if it's more urgent than that? So what if she's really quite anemic from her menorrhagia? She's been admitted for transfusion. You know, maybe she has some pre-existing disorder or has one with some acute episode that she's undergoing. So you really, you know, call us. We'll help you. And that's our GYN pager number. And then the OB resident who's on, that pager always is on 24/7. And I would say, so let's say you're not practicing here, you're out somewhere else. If there's a labor and delivery in your hospital or that's associated with your clinic, call them. They will know how to get a hold of the right person you should talk to. So call labor and delivery and say, who's on call for OB today? I have a, you know, bleeding adolescent patient. And you can do that here too. They always know where we are. Okay, but let's say you're on your own. There's no obstetrician for 90 miles, and you have this acute menorrhagic female under your care. So you'd still start with some oral estrogens. So you could start with a low-dose contraceptive, and you could just try doing 1 a day. And so you can just kind of go through this flow sheet, right? So that doesn't work. You can go to IV Premarin, which is that box under option 2. 25 milligram IV every 6 hours until the bleeding stops. It may not take a full 24 hours. Often 1 or 2 doses is enough. So it says for up to 24 hours. Usually you don't need that much. And then it tells you how to get yourself back out of that, right? So if you just do a huge estrogen dose, you fluff up that endometrium, you stop the bleeding, and you send her home. She's going to bleed as soon as that wears off, right? So then follow the continued how to wean her down off her estrogen, or again, call us now that you've managed the acute problem. Okay, I don't want to spend too much time on that. So back to the question about atrophic bleeding. So over time, so in a girl who's using the birth control pill, or she's atrophic for some other reason, she has premature menopause and, you know, premature ovarian failure. So what can happen? So what happens with the birth control pills? So all these pills are designed to be progestogenic, right? Because we don't want to give women endometrial cancer. So they all have a little bit more progestin than estrogen effect. And so over time, if you think about that lining, it gets very, very thin and kind of dried out and suppressed. And so with chronic pill use, you can get breakthrough bleeding, because then that lining, when it's very, very thin, while that's good, it can become a little bit unstable. Those, that basalis layer is exposed, and you can just get bleeding, intermittent bleeding. So what can you do about that? So you could try going back to your cyclic administration. So when you take that week off, what happens? The hormones surge again a little bit. Maybe she gets a little bit of estrogen, enough to beef up that lining and protect that atrophic bleeding. You could add a little extra estrogen. So if she's been on the pill for a long time and she's having this problem with breakthrough bleeding, she can just take a very low dose of estradiol with her pill for the few days that it happens. It tends to happen mid-cycle. And so maybe just for 2 or 3 days, she takes a little extra estrogen along with her pill. It does not affect the efficacy of the contraception and can help with the breakthrough bleeding. And it should not increase her clot risk to any significant degree. Or you can offer her an alternative method. We do find that if women have breakthrough bleeding on the pill, the ring may be more effective. Not sure why. Okay. So we don't really need to talk about this because, so sometimes in your adolescent patients, particularly those with severe developmental delay or some sort of post-surgical abdomen, pelvic and abdominal adhesion situation, it may be beneficial to provide permanent sterilization in some of those girls. And Bob Acton and I have had a couple of those patients together. But generally, you're not going to be counseling your patients about permanent sterilization. Emergency contraception. So Peter and I were just talking about this. So in a perfect world, emergency contraception should be available over the counter 24 hours a day to all women. Teens they can get it, but they have to get it from the pharmacist. So they have to talk to someone. And that's, I think, a barrier. So the first one is Plan B. I'm not promoting Plan B, so that's just what it's called. So you can just prescribe it that way, and that's how it is in Epic. The second one's called Ella, and I don't see that used as much here in the United States. It's probably a little bit more effective. And I don't think it's available in all pharmacies. And, certain pharmacies have decided not to carry these. So Walmart doesn't carry emergency contraception, and there may be other smaller pharmacies. So very effective. So this is up to 5 days after exposure. So you have unexposed penile vaginal intercourse, or you have unprotected penile vaginal intercourse. Up to 5 days later, you can administer emergency contraception. In our clinic, we have a protocol for the nurses. So if a patient calls and says, hey, can I get this thing, the morning after pill? Yes, it's done, it's signed, sent in. Yes, Tony? Mm-hmm. So in those cases, we're probably preventing implantation by creating a hostile environment. So we're interrupting that bed. What else am I going to say about that? I think that's it. And, we know that if you use it right at ovulation, it's less effective for that reason exactly. Okay. Better emergency contraception is the copper IUD. Probably the other IUDs are just as effective, they just haven't been studied. So you can see the failure rate is much improved over the oral regimens. Again, you can use it up to 5 days post-exposure. And you can't even use it, to get back to Tony's point a little bit more, so you can use it if exposure is more than 5 days, as long as it hasn't been more than 5 days since ovulation. So that kind of gets at your point a little bit there. Some sites use mifepristone for emergency contraception. In the United States, you have to be a mifepristone distributor, or You have to be an authorized mifepristone prescriber, which actually we are here at the University of Minnesota, but in your independent clinics outside of here you may not be. And I don't see that used a lot for emergency contraception, but it's an option. And then the old-fashioned USP regimen is basically high-dose birth control pill, like taking 4 birth control pills all at once. Pretty high dose of estrogen, not as effective, and has a lot more side effects with nausea and other things. Okay, so there's my summary again. So let's just talk about abortion just very quickly in Minnesota. So again, we do know that the rates are going down. Minnesota's always been better than the national average. So our teen birth rate is 22. Our abortion rate is 11 as compared with 19 across the country. But here's some things you might want to know for your patients. So all women in Minnesota require a 24-hour waiting period. So they have to talk to a physician. So once they've made their decision, I want to have an abortion, they have to talk to a licensed physician 24 hours before the actual appointment. And in Minnesota, that can be by phone. And it can be a different physician than the one providing the procedure. So in some states, it has to be in person. So you have a person missing work, missing school, 2 days to do their 24-hour consent and their procedure. For teens, in Minnesota, we have a 2-parent notification law. So you have to have a notarized signed letter from both parents if a teenager wants to have a termination. And so I think for many of us who work with teens, some of those teens can't even identify 2 parents, right? So it sounds really good, like it sounds really supportive, like this is a good way to help take care of teens, but in reality, it's somewhat problematic. The parents don't have to give permission, so the note doesn't have to say, I think this is okay. The note just has to say, I'm aware of it. But so if teens don't have that, they have to go through judicial bypass. So they have to go to the courthouse downtown, and they meet with a guardian ad litem who brings them through the process. They meet with a judge, and they get a judicial bypass. Of note, if teens want to stay pregnant and have a baby, they don't need any permission from the state to do that. They're automatically emancipated. Okay, so I think maybe, let me just see if there's anything else that I thought was really important. Oh yeah, okay. So I also passed around a printout of just the summary of this medical eligibility criteria, which is this green and pink thing here. So this is really helpful if you have one of those more complicated girls. So she has rheumatoid disorder, she has one of these coagulopathies, she has diabetes. And so the WHO has created this, it's a huge document, so I just printed a summary for you, but online you can find, this is kind of what it looks like. So if you have the diabetic girl who's insulin dependent with retinopathy and you want to put her on a birth control pill, which is the COC, combination oral contraceptive, you can see that's a 3 to 4. And so you go back and you say, oh, that's really not a good option for her. Let's look at something else. So this is just, it's really easy to find. You just Google WHO MEC, or just, I think if you even just do WHO contraception, you'll find it eventually. So this is a really helpful thing if you're trying to prescribe for one of your more medically complicated girls. Okay. And I think when to start this, so all in our practices, and it's considered standard, you can do immediate start with any of these regimens. So we used to make girls wait until they got their period to start their pill or start their ring or start their patch. You don't need to do that. You can just do today's start. Might their cycle be messed up this first time? Sure, maybe they'll probably just skip their period depending on how late in the cycle you start it. But we find that improves compliance significantly. And then also be sure to review with them what to do with missed or late doses. So, it's been 3 days, I forgot to change my patch, what should I do? Am I protected? Okay. All right, questions? Yes, hi John.
Thanks, Carrie. You talked about the use of contraceptives for non-birth control purposes, like menorrhagia. Mm-hmm. I know that some women use birth control to control perimenstrual symptoms. Most of what you talked about was use of oral contraceptives. You did mention, though, the use of the ring as a mucosal absorption method for delivering hormones in some of those cases. Is the ring used for some of those non-birth control contraceptive indications, or is that not an indicated use?
It is. So any of the hormonal methods that are systemic, so the ring, the patch, the pill, to me those are all equal. So we're going to suppress ovulation, we're going to suppress that cyclic, up and down of the estrogen and progestin. And so whether you're dealing with headache, endometriosis, acne, whatever sort of cyclic problem you're dealing with, that is going to help. With the progestin IUDs, that is a local effect. So that's going to help with heavy or irregular bleeding just because you're going to thin out the lining, but that progestin doesn't go anywhere else. So it's not going to help with acne control or PMDD, for example, because she's still going to ovulate on a normal schedule. She's just not going to bleed. Does that answer the question? Okay. Hi.
Hi, Carrie. Thank you for that very nice review. I wondered if you could address or talk about the relative advantages, disadvantages of the OCPs that are actually marketed as continuous versus using your standard favorite monophasic oral contraceptive pill.
Yeah, so I don't think there's any huge difference either way. The ones that have been packaged for kind of that 3-month use with the 1 month or 1 week withdrawal bleed, I think it's a fine comment. I forget which progestin it is, but I think it's a 2nd generation progestin, so it's not horrible. It's not any cheaper for patients, and again, the insurance coverage can be very variable just based on whatever deal that insurance company made with that, however they decide their formularies. So some patients like those, and they've been on those, and I think they're fine. It's just as easy, generally, it's just as easy to prescribe any of the birth control pills in a continuous fashion. Like I said, you just have to make sure the pharmacy is aware of what you're trying to do.
Thanks for that talk. I was struck by your comments earlier. You talked about fertility, and are we doing better with contraception, or is there some biological basis to think that fertility rates might be changing? And I wondered about Japan, where there's been this dramatic decline in fertility. And do you have any comments on that, or is there any biological basis to believe that it's biology and not behavior that's at play?
Right. I think there may be, and of course these kinds of public health studies are very difficult to do. So, so we've added growth hormone and other hormones to our dairy products and other products, for quite a number of decades, and so we don't know what effect that's had on children. I think the BPA metabolites. So we know that those act as estrogens, and could they be altering our reproductive systems or reproductive axes or tracts in some way that we're not aware of? And I think that's definitely possible. I worked with urology on a study measuring BPA metabolites in maternal urine, and so what we found is with higher, it's not very strong data, but there's a plausible association between higher BPA metabolites in maternal urine and a shortening of the distance between the base of the penis and the scrotum. So in essence, estrogenization of the male genitalia in the newborn. So that sort of makes sense that maybe, if women are exposed to really high BPAs, that could be having an effect. We do counsel women to avoid BPAs in pregnancy, not to microwave in plastic dishes, to buy BPA, if they're buying packaged food, to buy BPA-free packaged food, things like that. Are you guys counseling your moms and dads not to use BPA for newborns, kids? No? Most of the bottles are BPA-free now. I think if we went to Congress and said, we're turning boys into girls with plastics, I don't know, maybe we might get some legislation, maybe. Other questions? Still have 3 minutes. Peter.
Given the current political climate, I was struck by the comment you said I was struck by the comment you made early on about the improvement of maternal health with the availability of contraception. So really, to me, the talking point becomes contraception is associated, availability of contraception associated with the improved health of our populations, so it's a health issue. It's not necessarily a woman's choice issue. It adds another level of argument here, and I wonder if you can talk a little bit about that.
Well, it does, and my colleagues at UCSF, which you saw I borrow a lot of their slides, as well as the Guttmacher Institute and others. These are battles we've been fighting for a long, long time, trying to get women's health to be a focus of these sorts of decisions. We also know that access to legal, safe abortion improves women's health, right? Because women are going to continue to have abortion whether or not it's legal or safe, particularly if they don't have birth control. So, it's an argument we use. A lot of these institutions don't have huge amounts of money, although there is a large anonymous donor who continues to fund family planning institutions and or initiatives. But even with that influx of cash, it seems like in many states we've gone backwards. And I think so my dad said to me the other, I don't know, maybe over Christmas time, he said, Carrie, I don't really believe in abortion. And I said, Dad, I get it. No one really believes in abortion. Like, no one grows up and says, I'm going to get married and have 2 cars and 3 kids, 2 abortions and a dog, right? Like, no one gets pregnant so she can have an abortion. So what happens is women find themselves in situations. So here at this institution, we are referred a number of cases a year, feels like a number of cases, it's a lot of cases, of women with really devastating fetal anomalies. So trisomy 13 and trisomy 18 and anencephalies. And so these are wanted pregnancies with women who find themselves in a situation where it's not a condition that's going to result in a child, and so some of them choose to carry the pregnancy as long as they can until either there's an intrauterine fetal demise and they deliver, or to term and deliver and then do hospice care until that child dies, which might be days or weeks or months. Sometimes they even go home, and we provide that here. But some women choose not to do that, and they choose to end that pregnancy. And so is that a position that woman ever wanted to be in? No. And can any of us know what we would do in that position? Absolutely not, because you really don't know until you're in those shoes. And similarly with our teens, none of them plan on, maybe a few of them try to get pregnant. I think that's a failure on our part. But, most of them aren't out there trying to get pregnant. And probably the majority of them are the victim of some sort of sexual assault, right? It's some sort of date rape, or, maybe things went too far. And so, again, a teenager did not put herself in that position purposefully. And then that whole quarter of pregnancies that are unintended while women are using contraception, they clearly were not trying to become pregnant. So I just think, for me, I know it's really a hot political topic, but it really is a medical issue. And I think for us, it's women's health, and we can't separate it. We can't say, that's different from what we do, because it's so tightly linked, because it's just part of taking care of women. It's not to say that I don't recognize it's difficult, and I certainly recognize that it's a huge distraction politically. So it's used to get people really upset and distracted, and to keep people pitted against each other so they're not looking at your issues. Okay, I probably wasn't supposed to do that. Thank you. Thank you.